Hi everyone. One of the residents today had asked me to comment on the study of whether or not there is hypertrophic cardiomyopathy and outflow obstruction. And one thing I cannot emphasize enough is that outflow obstruction, the idea of the LVOT obstruction, is a physiological state that can happen in a lot of disease entities. It is not a disease entity in and of itself. You can have hypertrophic cardiomyopathy without obstructive disease at the LVOT. You can have hypertrophic cardiomyopathy with LVOT obstruction. You can also have severe aortic stenosis, or somebody that just had an AVR with now obstruction at the LVOT. You can also have a little old lady heart with a very small cavity and a septal bulge that's impeding, or what you would see it is here, impeding in the flow of the LVOT. So in this case, this patient actually does have an LVOT obstruction. One of the things that's markedly noticeable on this initial view in this parasternal long axis view is that the walls are very thick, and when the walls are contracting, you basically are obliterating the LV cavity. And if we were to take this moment in systole, here we go, and it's systole here. You can almost see how small, what a small tunnel that the blood has to go to in order to reach the rest of the body. So that's not a lot of space at all. So you kind of are creating a functional stenosis, a functional obstruction, and this obstruction, being as that the walls are muscular, is considered a dynamic obstruction, which means that depending on your hemodynamic state, such as high blood pressure, low blood pressure, hypercontractile LV, your gradients across the LVOT can differ drastically. So one of the things that always clues me into whether or not there is obstruction is exactly this. In this image, all you have to notice is there's a huge amount of color here. And you may take that for granted because we're used to seeing a huge amount of color everywhere, but that's actually not the case. When you have a very brisk flow across the LVOT, across the aorta, well, first of all, let's see where this is happening. This is happening in systole. Right here, QRS, systole, all this color mosaicing. Sure, you should be able to see some turbulence, but not this much color. This much color tells me that there is a ton of, there's a very high velocity flow going across. And for the echo fellows and the echo technicians, one of the ways to understand color is that what color represents is the mean velocity of flow across this LVOT. And just think about it. Here is your blood flow going perpendicular to the probe. So theoretically, you're really not even supposed to get any color, because any velocity that's going perpendicular to the flow, to the probe, should really be seen as a mean velocity of 0 based on the Doppler shift equation. The cosine of 90 is 0. So you really shouldn't see any color here. But the fact that you see high turbulent colors tells you that there is a lot of high velocity flow in this area. So just to remind you of what the color map means. So this color map means that anywhere you see a really, really bright yellow color, there is a peak of velocity of plus 60 going towards the probe. And whenever you see a really light blue cyan color, that's a negative 60 centimeters per minute flow going away. So whenever you see a really high velocity flow, this yellowish mixed in with this a bluish color, that just means there's crazy flow going in all different directions, aliasing and being just totally turbulent, kind of like I always think of a traffic going through the Midtown Tunnel, and during rush hour, it's just, well, I guess it won't be really fast, but it'll be super crowded and very chaotic. So moving on. So this is what we mean by color mosaicing. Don't take color for granted. It's because you will be expected to know what it means. Basically, a color at any point is the mean velocity of all the blood flow happening at that point. Okay. So let's move on to look at the short axis view, a very, very hypercontractile heart, completely obliterating the cavity during systole. Okay, now let's get to some money shots. Here is our 4-chamber view. Again, huge amount of color mosaicing and turbulence going into the LVOT. And now we're going to be starting to look at some velocities across the LVOT. So 4-chamber view, and now we're popping into the 5-chamber view, 4-chamber view, and now 5-chamber view. So initial CW across the aortic valve yields a Vmax of 366. Let's see how high we actually get. Up to 451, you get this classic dagger shape waveform for the CW across the aortic valve. That's indicative. That indicates essentially that this high velocity is not coming from the mitral valve and is rather coming from the LVOT, classic dagger shape. Now we're getting up to 479. Trying to localize where the velocity is, just to, and I guess the text is just trying to make sure that the high velocities are not coming from intercavitary. I think in this case it's probably going to be pretty clearly coming from the LVOT. So an LVOT, the PW at the LVOT, there's just so much velocity and turbulence here that you can't really see the end of this jet. And it's starting to wrap around here. So this phenomenon is called aliasing. So peak velocity in the 400s to 500s, and I suspect that we're going to see some very dramatic increases with Valsalva. So what happens during Valsalva is that you are decreasing the second phase of Valsalva maneuver, you're decreasing your afterload. So when you decrease your afterload, i.e. you can think of it simplistically as lowering your blood pressure. So you have this very high pressurized LV, so let's say upwards of 150 or 160 millimeters of mercury. And during Valsalva, your pressure drops in your aorta to, let's say, 80 to 90. So now you're going to have a huge gradient going from your LV to your aorta, and that results in very large velocities that going across the LVOT. So we went from 400s to 500s, and I think even up to 700 here. So this is, by the way, this is right here. That's a little trace of a mitral regurgitation jet, and this is here is the LVOT velocity, and a very nice envelope, and indeed very high velocities across the LVOT. Just one thing I will note that's kind of concerning in this case is that the person's heart rate is actually 50 to 60, which tells you that there's not much room to go in terms of slowing her heart rate if she has such a significant gradient and velocities at such a slow heart rate. This may be someone you may consider a surgical option, either septal ablation or myomectomy, to relieve that obstruction, because if they were to Valsalva or suddenly stand up quickly, they can very quickly completely obliterate their LVOT and cause syncope and fall and break their head and just be a really terrible thing. And I see this person is actually born in the early 80s, so they're actually really young. So that's something that this person may consider. Oh, very interesting. So here is the 3-chamber view, and I'm going to slow it down to show you here. In systole, you see that the mitral valve is turned into the LVOT, so there is systolic anterior motion as well. So let me just show you that again. So diastole, systole, diastole, systole, and systole, you're going to stop right here. You see that the tip of the anterior mitral leaflet is being drifting into the septum. What we always learned is that the increased turbulence and increased forces kind of sucks the leaflet in. I was recently in an echo conference where they said that may not necessarily be true, and the explanation was super complicated, so I couldn't even tell you what it is right now. But that's how I always remembered it, that there's so much turbulence here that the valve is being sucked in. Whether or not that's true or not, I guess remains to be determined, or is determined. just in, that's just the way that my mind is stuck on remembering it. So there is significant obstruction. So one thing that's interesting to see here also is that the mitral valve looks like it's even just completely touching the septum here. So that tells you that during this moment in systole, there's probably little or no blood flow actually going in through the LVOT. So a few more pictures just showing you how severe. Here it is again. There we go. See it? Right there. Right there. Right there. SAM. It's a really, really nice example of SAM. Okay, so I hope that was helpful. And so just in summary, this is a person with hypertrophic cardiomyopathy. Septum is measuring at about 1.7, so not really meeting ICD criteria by this alone, but I guess they would need some other testing to tell as well.